Okay, good afternoon, doctors. Let's see, I just need someone from my staff to actually let me know that we can hear me and see me just fine. So I just need somebody to type in that we can see and hear me just fine. Sounds good, can't see you. Okay, great. Let's get into show screen. Okay, good. Thank you for the help. All right, doctors, welcome to today's program. I'm going to be a little bit longer today because you're going to get the benefit of seeing some pretty sophisticated information that has to do with how to read and interpret a CRMA analysis. And by the way, CRMA is the registered trademark of spinal kinetics. So anyone out there using CRMA or computerized radiographic mensuration analysis other than spinal kinetics is actually in trademark violation. We did that because we wanted to actually really control the product that we were delivering. Now, the number one cause of pain and physical disability in the world today is the lumbar spine. The number 4 cause of pain and disability in the world and chronic pain today is the neck. The number 6 cause of pain and disability in the world today is related to the neck. It's actually headaches. So the topic of what I'm about to show you is so dramatically important, simply because the providers that understand it are they can absolutely take over their local either injury or their chronic pain market. And that's no joke. And what I mean by that is they can get attorney referrals, they can get medical referrals, they can get all kinds of referrals. They can go direct to patient groups to explain how they're diagnosing something that the majority of doctors in the market today cannot diagnose. So what I want to show you real quickly is musculoskeletal disease. I'm sure all of you are very aware of what I'm about to show you. 49% of the Americans actually have chronic problems. And if you look, these are medical visits for back pain. By the way, $253 billion worth. The chiropractic profession market, total market is only $14 billion. 61 on traumatic injuries. And we look at the population, 49% of the US population reporting that they have some sort of a chronic musculoskeletal condition. Sprains and strains account for 40% of all lost time injuries. They're more than that, actually. Calculators today place a low back injury at anywhere from 50,000 and above. And the dramatic part about that is if it goes out 3 years, some calculators are putting it at about 275,000. There's approximately 4.8 million work-related injuries a year, which costs employers a staggering $42,000 per injury. Now, quantification and understanding of what the patient has, if you look down here at this sentence right here, this is William Morris. He's a top researcher in the world for intersegmental pressure problems. It's been estimated that a precise diagnosis is unknown in 80 to 90% of all low back disabling conditions. In all low back disability conditions, 89 to 90% of the actual condition of what's causing is unknown. He also states here, over 85% of low back disabilities do not have a pathoanatomic diagnosis. Most traditional imaging is of minimal benefit for identifying the spine mechanical problems. And that's very true today. So chronic pain by the numbers is 100 million of them, 1 in 10. Go out to any football game, go out to any game, any place where you have 100,000 people and you have 10,000 of them in there that have experienced pain every day for 3 months or more in the year. Now, where does that pain come from? 61% of it, and I'm saying it's more than that, comes directly from the spine. So we got to have more spine doctors that actually understand how to diagnose. And it says here, this is where people go, but 9 out of 10 patients never know the primary cause, no matter who they go to. And that's the problem. Now, this that I'm just putting up here, I've done a lot of different webinars. This is the key to understanding why the ligaments are so important, because they cause a problem with the mechanoreceptors, which causes a neuromuscular control problem and it causes an instability in the joint. That causes abnormal stresses and strains, abnormal inflammation patterns, and those cause nerve interference of all kinds. So we know that there are basically wow, that's wild. Why did that? So we take from the ICA best practice, and I'm gonna move ahead to a different slide that has a picture of it. So let me get out of here and show for just a second. Let's see if I can't find one that has a picture of it. Good. So we know in the introduction to radiology that a chiropractor who's using radiology is supposed to do a couple different things. They're supposed to make an assessment for a spinal subluxation. We're going to talk about that. They're supposed to make an assessment and determination of spinal health, including the presence of any soft tissue injury. We're going to talk about that. We're going to make an assessment for any spinal instabilities. We're going to talk about that. Make an assessment of any disc and other degenerative changes. We're going to talk about that because the CRMA allows you to do all four of these. And most doctors don't actually understand how, and that's why we're on the program today. So what we're going to look at first is the subluxation. Now, don't get too uptight because the subluxation is a very cool word and it has clinical relevance today. We know that a subluxation is created by a trauma, whether it's a microtrauma or a macro trauma. And we know that trauma leaves derangement patterns behind. So all injuries are derangement patterns of the spine. So derangement is anything that disturbs the order or arrangement or the function of something. Now, subluxation is a bone on its normal position causing nerve interference. That's what it's always been. There were about, I think, 18 or 19 different subluxation patterns. There were static patterns. There were kinetic patterns, hypermobility, hypomobility. These are all subluxations. These are all the misalignment patterns that can cause the nerve interference that is a subluxation. So the key question here today is, if you're looking at this spine right here, is it subluxated? So let's just get, I want attendees to actually put in the question box. I want you to type in the question box, is that spine that you're looking at right now subluxated? Is there a subluxation in that spine? Yes or no? Just type in yes, 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 yes. Can't tell. Smart doctor. Totally. Can't tell. I have no idea. The only thing that the doctors on the program today see is a misalignment. They see misalignment patterns. But misalignments are not subluxations. Subluxations require nerve interference. They're a clinical entity. They always have been. So they require either pain, or they require a motor or a sensory problem that's consistent with the misalignment or mismotion pattern of the spine. Now, do you have to actually realign the spine in order to remove the subluxation? No. Most chiropractors are not. Okay, that's why you don't shoot re-x-rays, because the x-ray looks exactly the same as the first time you looked at it. Okay, all you have to do is remove the nerve interference and you've removed the subluxation. Subluxation never meant that you had to realign the spine. Just realigning the spine has very, very big benefits to it. So we said that what we're supposed to be doing is we're supposed to be, well, it's funny that we're supposed to be assessing for spinal instability. We're supposed to be assessing for spinal subluxation, spinal instability, the amount of soft tissue injury there is, and we're supposed to be looking for the disc. That's what we're supposed to be doing. right? So we look at this and we say, okay, does this spine right here, so this is what we're supposed to be doing, remember. So does this spine right here have a spinal instability? Well, let's take a look at that. Here's the definition of a spinal instability. It means that the ability of the spine has lost its ability to maintain its position under load, and when it does that, it creates either a neurological deficit or incapacitating pain. That's what a spinal instability is. Now, the major practical consideration and determination of clinical instability is the evaluation of the patient's radiographs. Radiographic examinations, the most often used objective means for determining the relative positions of the vertebral and potentially unstable spine. Therefore, it's important to give some consideration to the accurate interpretation and linear radiographic measurements. That's spinal kinetics, doctors. We go into great detail on the consideration of accurate interpretation of linear radiographic measurements. And that's the report that you're getting, right? So now I'm going to do something once real quick. We're going to duplicate that slide and we're going to bring it so that we're down. Well, we're not going to worry about it. Okay, so we just may have to go over it again. All right, so basically, get rid of that one. Delete. Good. So let's take a look at the spine. First of all, there's about 162 total joints in a human spine. Now, the spine has been degenerated by practitioners down to it's all just one big joint, and you just basically do a very minimal examination on it. You start adjusting it, and you get results with it. And that's kind of what's been degenerated down. So in injury work, if this person had a leg injury and the basic doctor came out and said, well, they got a lower extremity sprain, no one would buy that. Nobody would buy that, right? So there's about 30 joints here. Okay, the first question would be, well, what joints are problematic? Yet in the cervical spine, in the chiropractic, osteopathic, and medical professions, today what passes off as good diagnosis is they say, well, you have a cervical sprain. Well, there's some 31 joints in that cervical spine. What joints are sprained? And how bad? Where is it? Lumbar sprain, 27 joints. How bad? Where are they? Where is the problem? So remember, strains and strains are over 40% of all injuries. And the ICA came out with a position statement years ago that was one of the best position statements ever stated. It says, inherent in most spinal sprain and strain injuries, there exists a biomechanical neurological component of articulative malposition, referred to chiropractically as a subluxation. So there exists a biomechanical misalignment, neurological. Remember, we got to have a misalignment and neurological. Okay, referred to as a subluxation. And if not addressed and merely treated with soft tissue therapeutics or joint immobilization, forms of care may lead to joint fixation and instability and loss of motor integrity. Now, here's where it's big. It's the opinion of the International Chiropractic Association that such injuries, evidence of the chiropractic vertebral subluxation complex, should be analyzed and at present be corrected by specific chiropractic articular adjustments and procedures applied. Lack of such correction or articular misalignment may result in permanent impairment for waiting more than an hour, much less days, may lead to joint fixation, motion impairment, neurological insult, and or hypermobility of the inner vertebral motor unit. The biggest thing is here, what the ICA is saying here, you don't have to get too technical, is basically saying you can't wait. You got to get to somebody who understands this type of an injury right away. Right away. So if you look at the hierarchy of sprains, it's pretty simple. person injured their spine, 98% of them have a sprain finding. 25 to 33% of them will have a disc herniation. And some very small percentage of them will have a fracture. So if you look at that, you go, okay, gosh, if we're gonna be spine specialists, then we need to understand the injuries that our spines and our clients, our patients' spines go through. And we need to know how to work them up. So we look and say, gosh, there's 3 things that can happen, right? We can cause excessive motion. Now, you really can't have inherent in a sprain is ligament damage. And if the ligament damage is significant enough, you're going to have excessive motion. And you could also have a disc herniation. And you could also have a fracture, or you have a combination of all 3. So here's the really cool part. Remember, you're supposed to do a subluxation analysis, determine soft tissue injury problems. You're supposed to determine spinal instability problems, and you're supposed to determine problems with the disc. That's all on your x-ray findings. Okay, this abstract, predictability of severity of disc degeneration and disc protrusion using horizontal displacements of cervical dynamic radiographs. In this process, they found that cervical radiographs, I'm going to tell you lumbar radiographs are just as valuable, are high predictors for disc problems. So it says here that in the results of this study, the extension radiograph of C5 to C6 had the highest sensitivity, 93.33%, and a specificity of 100% in predicting disc protrusion, followed by C4, C5. Look at the percentages here. It's amazing. So what that means is that if we take a look at this, this is an extension. We look at this and we say, huh, this was traumatically induced. We have severe ligament damage here, and this is a high predictor for disc herniation. Now, characteristics of sagittal vertebral alignment. Let's talk about what are the normals. Well, the only study that was ever done that ruled out all injury patients was a study by Lynn. And what they found was that inflection rate let's see, where's the sentence start? That the differences of angular displacement were less than 7 degrees, and those of translation were less than 0.06 millimeters. So you round it up, you say 0 to 1 millimeter translation is normal. That's the considered norm. 1.01 to 3.49 is an abnormal range, grade 2 sprain. 3.5 millimeters is rateable, grade 3 sprain. 0.7 angular difference. So what does it mean by angular difference? It means if I've got a 12-degree angle on C5 and I've got a 11-degree angle on C2 or on C4, so I got a 12 at 5 and 11 at 4, I've got a 1-degree difference. But if I've got a 5 at 5 and I've got a 10 at 4, I've got a 5-degree difference. Still not a problem. But if I've got a 12 at 6 and I've got a 1 at 5, then I have 11-degree difference. So it's the angular difference. And we look at the angular differences and they tell us exactly what the sprain severity is. So the nice thing about spinal kinetics reports is they tell you where the abnormal segments are and they tell you where the rateable segments are. So they tell you where the grade 3 sprain findings are and where the grade 2 sprain findings are. And if your report comes back all normal, then essentially you have grade 1 sprain findings. And it's just that easy. Lumbar spine is exactly the same way. They're laid out right in the reports. I'll show them to you in just a second. You have the abnormal and established rateable thresholds right in the reports. Now, I'm going to step back for just 1 second. See, let me go back to no, I didn't put it in. Okay, I was just looking for a slide that I thought I put in, but I did not. Okay, so let me go back. So let's just take a look at this once. What's the severity here? This is a common report. Well, you look at that, those are grade 2 sprain findings. Those are abnormals. Those are grade 3 sprain findings. Those are ratables. They also qualify for being rateable in the AMA impairment guides. So if you had a motor or a sensory or a pain problem associated with those motor units, you have an active subluxation or an active spinal stability as well. So not only can you determine the severity and location of a subluxation, the severity and location of the ligament damage, the severity and location of a spinal instability, and the predictability potentially of a disc herniation from a single report. And it's just that easy. Now, we support the highest level of professionalism. That's what we do at Spinal Kinetics. Now, let's just take a look. All right, so you send in for a report. You look at this very first page, right? And it says cervical motion studies. This one just has a motion study. The angular is rateable at C3. That's a grade 3 sprain finding at C3 that you actually have. That's consistent with severe damage, severe injury to the ligament of the spine. So that would be a grade 3 sprain finding. Now, if you had a problem with a C3 or C4 nerve, right, you would have a subluxation or a spinal instability identified. Because remember, you got to clinically correlate those things. So this qualifies for the highest level grade 4 injury finding in the Cruft treatment guidelines. And it's just that easy. It also tells you, okay, great. So here at 3, you have a grade 3. Here at grade 4, at 4, you have an abnormal for angular finding. That's a grade 2 finding. So let's look at another one. All right, patient comes in. You look on cervical motion study. Geez, don't see anything rateable. Okay, fine. Now we go into here and whoa, we got abnormals at C5 and we got abnormals at C2, 3, and 4. So 2, 3, 4, and 5 actually show abnormal findings. So what do we have? We have grade 2 sprain findings at those levels. And if we have a motor, sensory, or pain problem associated with any of those levels, we have an active spinal instability and an active spinal subluxation. That's what we have. Now, what if we have a test that looks like this? Normal. It says the translation motion segment is below rateable threshold. The angular motion segment is below rateable threshold. All motion units measured in the study were within normal limits for angular variation, all within normal limits for translation variations. You're looking at grade 1 sprain findings, doctors, radiographically. Now, could you still have a subluxation? Yes. You have misalignment of the spine that's causing a problem, but that problem should abate a lot quicker than it would in a grade 3 sprain finding. So this is the way to determine the severity and location of the conditions that you treat every single day. Lumbar spine. Beautiful thing about it, you just look up and say, oh, angular motion segment integrity problem, rateable at L3. There's an L3 grade 3 sprain finding. If you've got a motor or a sensory problem associated with the nerves of that motion unit, you have an active subluxation or spinal instability. And we can look down here and go, well, we got abnormals at 3, 4, and 5. So we've got a rateable at 3, and 4 and 5 are showing grade 2 sprain findings. And that's how simple this is. It's the simplest test, and yet doctors try to complicate it. It's just that simple. Now, what's the science behind it? Let's do a little bit of science behind it. Observer agreement and flexion extension X-rays. Basically, what they said is, look, unless you're using some form of computerized assistance, when they took 6 medical doctors that routinely look at flexion extension X-rays, they could only agree 17% of the time on where the problem was with excessive motion. Whereas when they spent 15 minutes learning a system that's similar to spinal kinetics, they were able to come up with an agreement level of 77% on the problematic motion units. So the science is there. Spinal kinetics published its own research, which I'll show you just in a second. The AMA says motion of individual spine segments cannot be determined by physical examination. You can't tell me by physical examination that you have a 3.5 millimeter translation problem at C5 and C6 with your palpation skills. You can't tell me that you have an angular finding that's 17 degrees at C4 and C5 that's different from the motion unit above or the motion unit below, and it's 17 degrees of difference through palpation. Now, the beautiful thing about this is neither can any IME doctor. So it's quite significant. Spinal kinetics, we published information. We published research that says, look, if we have 100 spines, I believe we had 29 severe rateable segments in those 100 spines. We sent them out to a board certified spinal radiologist. How many of them do you think that they picked up? How many severe ligament damaged segments, if I ask the question, how many do you think that they picked up? None, 0. Absolutely 0. All right. Now, I'm seeing that I got a few questions, so let me see. Doctor, on the previous slide, how did you determine the injury was grade 3 and rateable when the movement was under 3 millimeters? I don't know. If it was under 3 millimeters, it's grade 2. If it was an angular finding of over, if there was an angular finding in it that was rateable, it would be a grade 3. Okay. Good. We also published a opinion paper that says a simple spinal sprain from whiplash, really that simple? No, it's not. And we also published spinal pain. Maybe it's not all in your head. These are opinion papers that we produced with spinal kinetics to contribute to the science of this. So the beauty of reading these reports is that they're seriously easy to read. They're seriously easy to read. I mean, you look at this, you look at the report, you look at the output. These are going to come back with 2 rateable translation segments. What are those? Grade 3 sprain findings. Okay, now if you got a problem with the nerve associated with the C4, C5, or the C5, C6 motion unit, you have a subluxation, you have a spinal instability, or if that problem with any of these segments that are abnormal. You have an active spinal subluxation, you have an active spinal instability. And without that, you don't actually have any understanding of what you have. Right? So if I'm sitting there in a deposition and you say, well, I've got a subluxation at C4 that's causing the problem, my first question is going to be, well, how bad is it and how did you determine that you had it? Well, I determined by palpation that I had it. Okay, well, good. How accurate is a palpatory examination? Because right now, doctors, with a palpation examination, I can go in for a $29 examination, and it'll include my exam, it'll include my adjustment, all in one visit. It'll my consult, my exam, and my first adjustment is 29 bucks. I can go to 400 locations throughout the United States and get that. Now the question is, what are you doing that's different? Because if you're an injury provider, you better be doing something significantly different, because the injury care model needs to have doctors that can identify the severity and location of the problem. Remember, employers right now are paying $42,000 per injury. Their back injuries are running $50,000 to $275,000 because they have doctors that don't even have the ability to give an accurate diagnosis. That's not coming from me. That's coming from top professionals and top people in the industry. So the time has never been more right for doctors to understand ligament assessments and to be able to perform those assessments. Doctors that can do that are very, very much able to go out and get a lot of referrals and a lot of patients, because there is a lot of patients walking around treating with doctors, and the doctors don't really have an idea of what's there, of what's really there. So it's very, very easy to actually determine the severity and location of a ligament injury. Really easy. Now, understand all the ins and outs behind it. If you seem like there was some confusion with what I said today, or you're not sure, anyone that's really, really familiar with ligament assessments went, okay, geez, that's a whole bunch of old stuff that Dr. Khan's been talking about. If you're not familiar with it, go to smartinjurydoctors.com, and I got a whole program, of training program that you can purchase. It's $1,500, $1,400. You can purchase it so that you can really up your game in this market, because this market is about to explode with need for doctors. It's already exploding. Plus, the doctors that really understand this will be the doctors that will get chiropractic insurance inclusion into the 100% coverage, no limit, because it would be that cost saving to the market to do so. And the market is just starting to look at it, but we need doctors of chiropractic that understand what they're doing, and not going, okay, great, you guys can have the market, but it's $29 for your exams and your x-rays, or exams and your adjustments. All right, now, if you want to know more about the way a CRMA is different from a MRI, then go to smartinjuryradiology.com and download this report. If you're new to spinal kinetics, or I don't care if you're old to spinal kinetics, but you're not using spinal kinetics, use them, especially in your trauma cases. If you're going to use them, there's 3 forms that you have to be able to fill out, and you have to shoot good x-rays. Today, we turn back x-rays, and we turn back providers that actually don't take good x-rays. We won't work with that provider. So, you know, we have doctors that are using spinal kinetics reports to determine where they're going to do injections, where they're going to do surgical procedures. And we have a lot of doctors that use it to drive all of their care procedures, so that they don't have a problem with somebody coming back and saying they did overutilization, they did various things that they weren't supposed to do, simply because their workups were inadequate. So it's very, very easy to get it right. So if you have any questions, or if you've not used spinal kinetics before, you want to actually go to 877-508-9729 and actually go to the Spinal Kinetics and put in, either call or put in a request right here. Start to learn how to use CRMA spinal ligament testing. Okay, now questions. Oh, very good question. Here's an awesome question. In a deposition, how do you explain to the attorney why are you adjusting an unstable motion segment? Good. So let's go back. That's a great question, doctor. If I were asked, so Dr. Kronk, why would you adjust an unstable motion segment? Great. My easiest example that I can give to you, doctor, is to stabilize it. Okay, let's go back to this slide. This is why in these reports, I mean, we have doctors that actually think that you can't, like if you saw that study right there, we have doctors that actually think you can't adjust any of these segments now. So let's go back to this slide right here, right there, that one. Okay. When there is a injured ligament, the mechanoreceptors go offline, and it creates a corrupted signal to the neuromuscular response pattern. So the muscles don't get the right communication so they can respond appropriately. Adjustments reverse that. They always have. They bring the mechanoreceptors back online so that neuromuscular control is reestablished and the muscles can assume control and take over for the damaged ligament. So that is the easiest thing in the world to explain. So why am I adjusting the spine? I'm adjusting it to stabilize it. I'm adjusting it in order to bring back the neuromuscular control to the muscles so they can stabilize the spine itself. And I do it over a course of treatment. I monitor through outcome assessment procedures, and I monitor my adjustments every single visit. If it was damaging the patient in any way, I would see it right now. So that's how I explain it. All right. Are you able to discern if it's an acute or chronic injury through the report? You are able to, as a doctor, through the correlation of the report with what you actually examine. Yes. Do you offer training to at least see how the radiologist calculates the numbers? The only thing admissible in a court is my opinion, not that of a radiology report from the MD that is not there to testify. No, that's actually not true. Your medical treatise is admissible in court, and your medical treatises say what the consensus of the doctor says information means. Those are admissible in any court in the country. So it's very easy to get information admissible in court. And when you say your opinion, again, you need to look up your admissibility rules. I believe it's 702 of the Federal Rules of Evidence that allow all medical treatises to actually be entered into the court. So if you have the AMA guides, if you have the ICA best practices for radiology, anything that you rely on is admissible. And once it's admissible, it can be read. Oh, the AMA says that absent severe trauma, this finding is not there. And all the other things. So admissibility is very, very easy. And it's only confusing because you're working with the confused. You're working with confused attorneys. You're working with other doctors that are confused. Confusion is contagious. Don't catch it. So it's very easy to get this stuff into court outside of your opinion. Okay, how do I explain what you just said to my attorney? How you explain is you understand it yourself. And that's why I have a training program. That's why I have a Smart Injury Doctors training program, is to really up doctors' game on being able to explain what I'm explaining to you today. Because it's really that easy. And without an excessive motion test, you don't know. You do not know the severity location of the ligament injury itself without it. That's why on the beauty, I've been saying this for years and years and years, that an excessive motion test will actually tell you, it'll give you a good idea of where you actually have disc herniations. Now, it's only in the lower levels, right? You don't see many disc herniations at the C2 disc. But at the lower levels, C3, C4, C4, C5, C5, C6, C6, C7, it's highly predictive of disc problems. And that was published January of this year. I'm sorry, June of this year. So the science is now catching up. It's just for the providers that have been using this, they realize the science is catching up, and they're doing an awfully good job in the market today, because you can take this information out and you can start to be the ones that help to get insurance inclusion to come back and state work comps to come back, things like that. Okay. Any other questions? Okay, what was the website for the training was smartinjurydoctors.com. And what I would highly recommend is if you get on that program, if you're going to be involved, I'm coming out with some big things, a national smart injury help website. We'll have probably when we come out and launch, we'll have 200 and maybe 30 to 240,000 professional profiles already on the site. And the site's total program is to direct local people to the best doctors in their area for treatment, for injury treatment. So you go out to smartinjurydoctors.com, join the training program, and it allows you to actually get certified in a very specific area of spinal ligament testing. And then you can actually be documented as one of those doctors in a premium, in the premium site. Okay. Any other questions? Okay, that's all I have for you then, doctors. Thank you very much for your time. I appreciate it, and we try to bring you programs twice a month that are of value. We'll continue to do that, and we continue to appreciate you sticking with us and getting this information and then actually using it and applying it. Doctors, have a great day.